Cholesterol cholelithiasis is one of the most expensive digestive disorder in the Western countries. At least around 20 million Americans have gallstones disease, and around 1 million of these cholelithiasis patients, they usually come up annually. If we talk about on an annual basis, there are around 1 million of patients with cholelithiasis who are diagnosed. Mostly, this cholelithiasis is usually very silent, but around one third of the population with cholelithiasis, they come up with some symptoms and complication later on. And about 700,000 cholecystectomies are performed every year on an annual basis. So if we talk about cholelithiasis, as you all know, it means the formation of stones within the gallbladder. The prevalence of the gallstone appears to be rising due to the reason of obesity. And the obesity that is usually associated with insulin resistance and that has some metabolic syndrome. In addition to that, there are some unavoidable complications of gallstones, which ultimately reaches to up to 3,000 deaths on an annual basis. If we talk about the US, the gallstones disease is usually increased overall on the basis of the gallstone disease, and it's increasing day by day. If we talk about the prevalence and the incidence around the world, the high prevalence of gallstone disease, cholelithiasis, is usually more common in the Western culture, which is around America, Canada, Western Europe, and some parts of Australia. If we talk about the intermediate incidence of cholelithiasis and gallstones, it's usually around the Eastern Europe, such as Russia, and then there are some parts of China, India, and some parts of Middle East, such as Saudi Arabia. They have intermediate incidence of cholelithiasis. And if we talk about low or almost nil incidence of cholelithiasis, these are usually the parts of Africa, which is North and South Africa. So overall, we can see that the Western population, they usually have cholelithiasis the most. So if we talk about the types of gallstone, based on the chemical composition and the macroscopic features of these gallstones, they're divided into three different types. One being called as the cholesterol stones, and then we've got the pigment stones, and lastly we've got the rare stones. So if we talk about the cholesterol stones, around 75% in the US and Europe, the gallstone disease is usually because of the cholesterol stones. These are usually subclassified into pure cholesterol, which is completely made of cholesterol, and then we've got the mixed stones, which contains 50% of the cholesterol. If we talk about the pigmented stones, we can subdivide it into brown pigmented stones and black pigmented stones. If we talk about the ratio, it's the pigmented stones as compared to cholesterol stones, they are around 4.5%. And if we talk about the black and the brown pigmented stones, the black is around 20% and the brown is around 4.5%. And lastly, if we talk about the rare stones, they are usually very, very rare, and the percentage is around 0.5%. If we talk about the gallstones on the basis of location, they're usually present intrahepatic, and then they're usually present in the gallbladder, and they're usually present in the bile duct. If we talk about the intrahepatic stones, they're usually the pigmented stones, which is more specifically the brown stones. If we talk about the stones in the gallbladder, they're usually the cholesterol stones and the black stones. And if we talk about the stones that are present in the bile duct, they are usually the mixed stones, which is a subclassification of the cholesterol stones. So if we talk about the risk factors, who are the people who are more prone to having gallstones being formed within their gallbladder, bile duct, or intrahepatically? So if we talk about the risk factors, first being the age and gender, like we've mentioned that females are very prone to develop gallstones. And specific sort of diet is also one of the reasons why gallstones are being formed. Pregnancy and parity is also the more a female has number of children, the more chances she have, the more risk she has to develop gallstones. And then if someone is having a weight loss which is very rapid, so they are also prone to having gallstones. Total parenteral nutrition in such patients who are having digestive problems and who have some small bowel or large bowel diseases, and who are admitted in the hospital and they're going through TPN, which is total parenteral nutrition. So they're also prone to develop gallstones. Biliary sludge drugs, if we talk specifically about the drugs, it could be estrogen, lipid lowering drugs, for example, the drugs that we are given to patients with high cholesterol, octreotide and ceftriaxone. So these are the drugs that are at a risk to develop gallstones and then ultimately cholelithiasis. And then there are some lipid abnormalities that can also prone, because is one of the main stones that are being formed. So high cholesterol dietary intake can also cause increased gallstone formation. And lastly, there are some systemic diseases that are prone to producing gallstones, such as obesity and insulin resistance, like I've mentioned before, diabetes mellitus, diseases of the ileum, and lastly, spinal cord injuries. So these are the list of the patients with these systemic illnesses. They are also prone to develop gallstones and ultimately cholelithiasis. So, if we talk about the protective factors, statins also have a protective factor, because the patient is already taking statins for his disease, which is hypercholesterolemia. So, taking these drugs such as statins, they lower the cholesterol level and ultimately they help in lowering the formation of cholesterol stones. Ascorbic acid. Ascorbic acid, the patients with increased ascorbic acid showed to have almost 13% of low prevalence to developing gallstones. Other than that, coffee intake. It's very interesting to know that a person, if he drinks around 2 to 4 cups of coffee on a regular basis, daily basis, they usually they decreases the risk factor of developing gallstones to almost 40 to 45%. So people who are taking lots of coffee, they are usually protected against the formation of gallstones. And other than that, we haven't seen a lot of benefit in people who take decaffeinated coffee. So the proper coffee is one of the reasons why a patient might not develop gallstones. So if we talk about the cholesterol gallstones, to be more specific, the cholesterol gallstones, they usually contain three different types of substances, such as the cholesterol monohydrate crystals, and then they might also have the amorphous calcium bilirubinate, which is one of the main factors that is also present in the pigmented gallstones. Other than that, they also might have calcium carbonate or calcium phosphate within the stone. So these are the three different things that we might find in the cholesterol gallstones. Other than that, like I've mentioned before, that cholesterol gallstones can be subdivided into two groups, one being the pure cholesterol. Pure cholesterol have almost around 95% of cholesterol and some precursors of cholesterol, which is 5%. And the other type of subclassification of cholesterol gallstones includes the mixed gallstones, which might include cholesterol and some bile salts, phosphates, and some parts of water. So 50% is around cholesterol. So coming to the pathophysiology of the cholesterol gallstones, there are five primary defects that are ultimately that get into the formation of cholesterol gallstones. So what usually happens that there are the 5 defects that I'm going to be discussing with you. These 5 defects, they act together and they ultimately forms the cholesterol nucleation and crystallization, and then it completely gets into the formation of cholesterol gallstones. So what are these 5 primary defects? The first being the genetic factors and LITH genes. So there are some genetic factors that are responsible for the formation of cholesterol gallstones. We can see that there are some genetic predisposition that assist the formation of cholesterol gallstones. These genetic predispositions are usually present in the North and South of America, and being more specific, the North and South American Indians. So they are the ones who usually display the highest prevalence of cholesterol gallstones, which is around 48% as compared to the rest of the world. So if we talk about the intestinal factors, studies have shown that these studies were usually done on mice. So those studies showed that the increased dietary intake and the increased efficiency of the intestine to absorb the cholesterol from the intestine usually causes the development of cholesterol gallstones. If we talk about the hepatic hypersecretion, so what usually happens is that supersaturated bile salts, they usually contain cholesterol, and they cannot be solubilized by phospholipids or by water. So they usually end up developing into cholesterol gallstones. So this cholesterol supersaturation, it usually happens because of the excessive hepatic secretion of cholesterol, and then there is a decreased secretion of bile salts that helps in neutralizing the cholesterol, and then the combination of these both two, that there is hypersecretion of cholesterol, and then there is hyposecretion of the bile salts that neutralizes or solubilize the cholesterol. So the hepatic secretion is one of the factor. If we talk about the gallbladder hypomotility, so what usually happens is that in a normal physiological response, the gallbladder contracts multiple of times during the day. So it also has been seen that hypomotility of the gallbladder, it could be because of any infection or the inflammation of the gallbladder wall. So this causes the hypomotility of the gallbladder and ultimately formation of gallstones. And lastly, if we talk about the rapid phase transition, which is the cholesterol nucleation and crystallization. So this usually happens when the solid cholesterol plate is being precipitated and supersaturation occurs, and thus the formation of cholesterol stones occurs. So if we talk about the pigmented stones, these pigmented stones, they usually are the black and the brown stones, like I mentioned before, and the pathogenesis of this pigmented stones is usually not very understood, and there haven't been a lot of studies done. But we've seen that each type of these stones, which is either the black stone or the brown stone, they usually have a distinctive pathogenesis that results from the abnormalities of the production of the bilirubin. So what usually happens is that bilirubin is not properly metabolized, and the pigment in the black and brown stone is usually because of the bilirubin. So if we talk about the black stone in specific, the black stone is insoluble and it is a polymer of the calcium bilirubinate. And if we talk about the brown pigmented stones, they are usually the monomer of the calcium bilirubinate. And we've seen that these both stones, they usually differ in a lot of ways, such as the color and such as the radiodensity and the geographical location within the body. So that where are they really formed or produced within the body. So if we talk about the black stones in specific, black stones usually they are around 20% of the pigmented stones, and they usually are formed in the uninfected gallbladder. So the gallbladder is not infected, but it could be in patients such as patients with hemolytic anemia or any ileum disease, or they might also have an ineffective erythropoiesis. So these are the patients usually who develop black stones. We can see that this usually happens because of the bilirubin that is not metabolized, and then it results into unconjugated bilirubin. And so these stones, they usually have the pigment because of the bilirubin. So if we talk about the second type of stones, which is the brown stones, the brown stones, they usually look like this. These brown stones, they usually contain calcium salts, and other than that, they've got a lot of different things such as phospholipids, they've got some fatty acids, some parts of water, and some parts of cholesterol. If we talk about the shape of these stones, they're usually very irregular and molded type, and they might range from being reddish brown to almost dark brown. Other than that, if we talk about the brown pigment stones, like I mentioned, they consist around 4.5% of the gallstones overall. So if we talk about the pathogenesis, like I've said, it's not really understood, but we have a little know-how of the pathogenesis. We'll be describing this in the picture. The pathogenesis, in this we can see that bilirubin glucuronides are usually being broken down into free bilirubin. So this is done with the help of bacterial beta glucuronidase. So what usually happens in normal phase, what happens that the B-glucuro-1,4 lactone, they usually inhibit the endogenous beta glucuronidase. So they usually inhibit this, and then the free bilirubin is not being formed. But for the formation of the stones, bilirubin glucuronidase is causing the formation of free bilirubin. Other than that, we can see that phospholipids are also one of the reasons why these stones might develop. With the help of phospholipase A1, free fatty acids are formed, and like I mentioned before, that these brown and black pigments, they usually have free fatty acids too. We can also see that conjugated bile salts, with the help of bile salts hydrolase, they form into free unconjugated bile salts, and ultimately they all are helping in the formation of brown pigment stones. We can also see that calcium, with the help of calcium bilirubinate, when calcium is combined with some bilirubin and some parts of water, they develop into brown pigment stones. Other than that, any dead bacteria or any debris, they are also helpful in the formation of brown pigment stones. And lastly, mucin gel, they also help in the formation of brown pigment stones. So in this picture, we can see that brown pigment stones, they consist of all these different types of composition, such as bilirubin glucuronidase, and then phospholipids, and then some bile salts, calcium, some dead bacteria, and some mucin gel. So if we talk about the natural history of the formation of gallstones, the gallstones, they're divided into two groups, such as asymptomatic and symptomatic patients. So asymptomatic patients are usually in majority because these stones, they usually are present within the gallbladder and they do not show any symptoms. And then we've categorized some of the patients into the symptomatic patients. So this will be a schematic depiction of the natural history and the complications of gallstones. One being the asymptomatic stone, like I mentioned, that there are some stones that are present inside the gallbladder and they are completely asymptomatic patients. They don't come up with any sort of symptoms, not even any pain. So these are usually around 75% of the population who don't show any symptoms. And then there are some people, they usually have long-standing cholelithiasis, which results into gallbladder carcinoma, which is one of the complications of gallstones. So they have stones that are present in the gallbladder and it's there for a very, very long time. And ultimately, that causes some changes within the walls of the gallbladder, and ultimately, it causes carcinoma. So this is around 0.1%. This is a very low percentage as compared to the asymptomatic stone. And then there are some stones that intermittently obstruct the cystic duct, causing intermittent biliary pain. So biliary pain and the symptoms, they usually develop when the stone, it moves from the gallbladder pouch and it goes into the cystic duct. So these patients, they're usually around 20% who do develop some symptoms, starting with the biliary pain. And then there are some patients who develop a stone that is impacted in the cystic duct, causing acute cholecystitis, which is around 10% of the patients. And these patients, they come up with the sign and symptoms of right upper quadrant pain and fever. And these patients, they're usually female, and they usually require treatment as soon as possible. Sometimes the stone may also impact the cystic duct, compressing or fistulizing into the common hepatic duct, causing the Mersey's syndrome. So this is around 0.1% of the people, and it causes that the stone, it fistulizes into the common hepatic duct and causes this Mersey's syndrome. And then we can see that the stone impacted in the distal bile duct, causing jaundice and biliary type of pain. So these types of patients, they're also around 0.1%. And as you can see, the bile duct that is connected to the duodenum, it is also impacted, and thus the bile salts and the bile is not discharged into the intestine. And lastly, if we talk about the stone eroding through the gallbladder into the duodenum, resulting in cholecystoenteric fistula. So fistula is also formed, and then it's also stopping the formation of bile and the discharge of bile into the duodenum. So these patients, they're also around 0.1%, not a majority, and but as compared to the asymptomatic stone, who are usually 75%. So, if we talk about the clinical disorders, what are the different clinical disorders compared to gallstone disease, cholelithiasis? So, this could also be one of these complications that usually erupt with the gallstone formation. Gallstone formation being asymptomatic if it's present within the gallbladder, and then what happens if the stone, it comes out from the gallbladder pouch and it disrupts or impacts any other tube within the gallbladder or the intrahepatic or the bile ducts. So, if we talk about the different clinical disorders, first being the biliary pain, which I mentioned before, that 75% of the patients who are usually asymptomatic, around 20% in comparison to that, usually do develop biliary pain. So, biliary pain usually happens when there is a stone impacted within the lumen of the gallbladder. So, if the stones from the gallbladder pouch, they impact the lumen, the tube of the gallbladder, so this causes usually the biliary pain, and it's also called as biliary colic. And then we've got the acute cholecystitis if the impaction of the stone causes the inflammation of the gallbladder, so it's called as acute cholecystitis. And then choledocholithiasis is also one of the formation of gallstones. And lastly, cholangitis, which is the inflammation of the bile duct, which ultimately happens because of the impaction of the stone within the tube. So, if we talk about biliary pain, one of the first clinical disorders. It is the most common presenting complaint that a patient usually comes up in the outpatient department, and it is the most common symptom of cholelithiasis, gallstone disease. And about 75% of the patients who are symptomatic with gallstones, they do come up with the pain, and they seek medical attention because of the presence of pain in the right upper quadrant. And it's usually very bad, and the patient, they seek medical attention for that. Other than that, if we talk about the biliary pain, like I mentioned, it's the most common, and it is also one of the treatable cause. So patients who usually come up into the outpatient department, they are treated accordingly. Painkillers, they usually do not help that much, but they are then supported with the help of some surgery done. So, if we talk about the pathophysiology of biliary pain, what usually happens is, like I've mentioned in this diagram, that there's the gallbladder, and the stones, they're usually present within the pouch of the gallbladder. So these stones, they come up and they disrupt or impact one of the tubes. It could be the bile duct, it could be the cystic duct. So this stone that is impacting the bile duct, then it's called as biliary pain. So it causes pain and inflammation. So these are the symptoms that the patients usually present with. So this is the gallbladder, and this is the gallstone, which is blocking the common bile duct. So this is an intermittent obstruction of the cystic duct, and usually there's not a lot of inflammation, but it's only the impaction of the stone that usually then passes out into the duodenum, or usually passes out, and then the biliary pain, it's usually settled. So if we talk about the biliary pain, first being the severe pain, like we can see that the pain usually it starts off, and it usually starts off after a meal, and the intensity, it usually gradually increases over 10 to 15 minutes, and then it might remain constant for around 6 hours. This could be the epigastric pain, that is usually on the left side. It could also be some visceral pain, and with that, the patient, they usually develop nausea. In a lot of cases, they usually develop nausea, but there's no vomiting with that. Then the patient might feel some gas, they might feel some bloating, flatulence, and dyspepsia. But these sort of symptoms, they're usually not associated with the stones. It's just the inflammation within the bile duct. So if we talk about the physical findings, often the physical findings is usually normal, because the impaction of the stone does not develop very nasty big features such as hepatosplenomegaly or any Murphy sign that is usually seen in patients with acute cholecystitis. So it's usually normal, but there might be some mild to moderate epigastric tenderness during the attack, and then there might be some mild residual tenderness that lasts for days. So like I mentioned, there might be a constant effect of the pain, which is not relieved until and unless the patient takes some painkillers. So if we talk about the laboratory findings, this is also usually normal. There might be some elevated serum bilirubin, and along with that, there might be elevated alkaline phosphatase and elevated amylase. So alkaline phosphatase and amylase, they coexist together, and they usually it predicts the formation of a bile duct stone. So during a bile duct stone, there might be elevated alkaline phosphatase and amylase. So, if we talk about the diagnosis, what are the ways that we can diagnose a patient with biliary pain and the impaction of the gallstones? We usually, the foremost and the most common way of diagnosing a patient is the ultrasound, as it's one of the simplest way. We use the ultrasound probe around the epigastric region, and we might see some stones that are impacting the lumen of the gallbladder. And then there are some oral cholecystography, which is also helpful in diagnosing, but it's usually done on a very high scale. And lastly, there's this Meltzer line test, which is also helpful in diagnosing the stone within the bile duct. But this is usually very rare, and it happens in a very big setup. So if we talk about the biliary pain and the gallstone that is impacting the bile duct on the basis of ultrasound. So this is an ultrasound image, and what we can see in this is this black structure over here is the gallbladder, and this is the gallstone that is impacting the lumen of the gallbladder, and this is an acoustic shadow. So as you can see that stone is very, very visible, and thus with the help of ultrasound we can notice that there's a presence of stone, and ultimately the diagnosis of gallstone and the diagnosis of the biliary pain is usually done. So if we talk about the biliary pain differential diagnosis, usually a careful history helps in ruling out other diseases related to gallstones, and it's very necessary to rule out other gastro or other intestinal diseases first. So what are the differential diagnoses? One being the reflux esophagitis. As the patient, they usually present with epigastric burning. So we could also think of some esophagitis, reflux esophagitis that is happening. Peptic ulcer also, because the patient present with a pain that is very vague, and it's not usually the right upper quadrant. It could shift somewhere else, it could shift to the back, it could be a visceral type of pain. So we could also rule out peptic ulcer first. Pancreatitis is also one of the reasons why we should be ruling out, because as this is a very dangerous disease, so it's supposed to be ruled out first. And as the patient, they usually present with very, very severe pain right in the middle, so we need to rule out pancreatitis. And then renal colic could also be one of the reasons, as the patient might say that the pain is shifting towards the back side, being more on the right side. So this could be one of the things that we should rule out. Diverticulitis also presents in the same way, so we need to rule out diverticulitis. Carcinoma of the colon, it's very rare to rule out this. It might be depending upon the age. If the patient is an older patient and if he's male, so we need to rule out this. But we need to ask other symptoms also, such as altered bowel habits and any bleeding through the rectum. So this is a very rare condition. Radiculopathy, and lastly angina pectoris, because the patient might present the pain going towards the chest. So epigastric pain, as you all know, that heart attack also usually presents with pain that is epigastric. So we need to rule out angina pectoris too, with the related history that has been done. And lastly, if we talk about the treatment plan of patients with biliary pain and gallstones, patients with recurrent uncomplicated biliary pain and documented gallstones, they are usually sent into the elective laparoscopic cholecystectomy. As you can see in this picture, this operation that is going on is a laparoscopic cholecystectomy. So it's usually done with the help of a camera, and then we can see through the screen what is going on, and then we can remove the gallbladder as a whole with the help of the devices. So elective laparoscopic cholecystectomy is also done. So now if we come to the another clinical disorder regarding gallstones is acute cholecystitis. So acute cholecystitis is the most common complication of gallstone. Usually, patients with acute cholecystitis are females and they're around 40 years old, and they're usually their parity is very high, so they might have a lot of children. So, if we talk about the inflammation of gallbladder along with right upper quadrant pain, and if the patient has fever, and if we see in the lab test that they have leukocytosis, these are the hallmarks of diagnosing the patient with acute cholecystitis. So this is a histological diagram of patients with acute cholecystitis. As we all know, it's the inflammation of the gallbladder that occurs. So usually the layers of the walls of the gallbladder is usually very inflamed. As you can see in this histological pictures, there's a lot of space in between. So, if we talk about the pathophysiology of acute cholecystitis, if we examine the patient within the first few days of the attack, they usually have a gallbladder that is inflamed, and we can also palpate the gallbladder in some chances. And the gallbladder is usually very distended. It's usually because of the impaction of the gallbladder stone that is within the bile duct, and it overall causes inflammation. And there are some chances that it might predispose into secondary infection in around 50% of the patients. So, if we talk about the pathophysiology, like I mentioned, obstruction of the bile duct, and then there is also a chance that the hydrolysis of the luminal lecithins by the mucosal phospholipases. So, like I've mentioned before, that there are a series of processing effects of these that causes the inflammation of the gallbladder. And then there's also production of some toxic materials such as lysolecithins that also causes the inflammation of the gallbladder. And then there might be a disruption of the mucus layer, which is the glycoprotein mucus layer, which causes the formation of acute cholecystitis. There might be an exposure of the epithelium to direct detergence action of bile salts. So the bile salts that are coming from the gallbladder, they are also interacting with the inflamed gallbladder, which causes acute cholecystitis. GB dysmotility, it could also be the reason, like I mentioned, that the gallbladder, it goes into hypomotility, it doesn't contract on a regular basis, and it also causes the inflammation. And then there might also be the gallbladder distension and the increase in the intraluminal pressure. So what really happens is that the pouch of the gallbladder, it increases in the intraluminal pressure. So the stone is impacting the way out, the lumen of the gallbladder, and the pressure within the pouch, it increases, and it also predisposes to acute cholecystitis. The blood flow might also be compromised, which could cause ischemic like pain, and then finally inflammation. Like I mentioned, gallbladder inflammation is also called as acute cholecystitis. So, if we talk about the symptoms, 75% of the patients with biliary pain, they usually result into the formation of acute cholecystitis. So, like I mentioned, biliary pain, visceral or epigastric pain, it could radiate around and could give false diagnosis, and then back pain, which could mimic acute pancreatitis. And then the right shoulder pain. This is very specific for acute cholecystitis. So if a patient comes up with right upper quadrant pain and some fever and leukocytosis, and being more specific, a female patient might present with right shoulder pain. So this could be acute cholecystitis. And then chest pain, so we need to rule out any sort of heart attack. And finally, nausea. The patient might present with nausea but not necessarily vomiting. So if we talk about the physical findings, one being fever. So fever is usually not more than 102 degree Fahrenheit. but usually it's more than that if there is any perforation done and causing peritonitis or any gangrenous sort of gallbladder. And then some right subcostal tenderness, that is usually the Murphy sign that is usually seen in the physical finding, the physical examination of the abdomen. Murphy sign would be positive. And lastly, mild jaundice. Jaundice is usually seen in patients around 20%. Other than that, there might also be a palpable gallbladder, which is seen in around 33% of the patients. So now if we come to the laboratory findings, leukocytosis, like I mentioned before, it could be because of some infection, because of the inflammation. So the WBC count would be increased. Increased serum bilirubin, which is around 2 to 4 milligram per deciliter. There might be an increased aminotransferase, increased alkaline phosphatase. Amylase might also be needed to be done to rule out pancreatitis if it's very, very high, and then increased lipase. So if we talk about the amylase and lipase, if it's high together, so it usually depicts stone as compared to pancreatitis. If we talk about the diagnosis, how are we going to be diagnosing acute cholecystitis? Like I mentioned before, the simplest method to rule out any stone within the gallbladder would be ultrasound, which is available almost everywhere. So it's very helpful in this way. And then we have our hepatobiliary scintigraphy, which is also usually done on a basis if we can't find out the gallstone with the help of the ultrasound. And then lastly, abdominal CT is also needed if it mimics some other things such as pancreatitis, or it mimics any other colon cancer. So we need to rule out those things too. So if we talk about the imaging, this is a picture of the ultrasound which we would be doing on the patient. As you can see, it mimics the ultrasound picture that we've seen before. This black area over here is called as the gallbladder, and then these things are the stones, and this is the acoustic shadow that we can see through the ultrasound. Other than that, we can also notice that there are some gallbladder thickening in patients with acute cholecystitis, such as this patient. So there's another way to see the acute cholecystitis is the cholecystography. So this is a scintigraphy gam. So what usually happens is that patients, we give them an injection of diisopropyl amino diacetic acid. So after taking up the injection, this is the image that we can see after 5 minutes of taking up the injection, and then accordingly these are after a few 10 minutes, 5 minutes pictures, and lastly this is the image that can be seen after 60 minutes. So usually what do we see is that the entry of the duodenum is being contracted and is being blocked because of the formation of the stone that is obstructing the cystic duct or the bile duct. So the principal conditions that is very necessary to be ruled out first, and from the acute cholecystitis and the differential diagnosis, one being appendicitis, as these patients, they also usually present with acute pain and nausea and vomiting. So this is also one of the reasons. If the patient is very young, so we need to rule out this too. Acute pancreatitis, like I mentioned before, we need to see if amylase is raised or not. The patient might present with severe pain that might be radiating towards the back. Pyelonephritis could also be one of the reasons why the patient presents with a pain that is usually very on the side and on the back. Renal calculi, like I mentioned before, it also mimics a picture of renal calculi. So it could be some renal stone. So the pain is supposed to be differentiated. Peptic ulcer, like I mentioned, that the patient might present with some epigastric pain. So any sort of peptic ulcer disease or epigastric burning should be ruled out. Gonococcal perihepatitis is a very rare condition, but it's also in the list of differential diagnosis. Acute hepatitis, because it usually does not present with pain, but if the patient presents with some jaundice, along with the acute cholecystitis, so hepatitis is also needed to be ruled out. Pneumonia could also be one of the reasons why. And lastly, hepatic tumor, if the patient has a history of hepatitis, or if the patient is a very old aged patient. So hepatic tumor is also one of the differential diagnoses that needs to be ruled out. So if we talk about the treatment of acute cholecystitis, there are two treatments that is very necessary. One being the laparoscopic cholecystectomy and the open cholecystectomy. So laparoscopic cholecystectomy is usually done in patients who are fit and who can undergo the surgery, but open cholecystectomy is usually not done in patients who are not fit, because open cholecystectomy would be the same as laparotomy, having a big incision in the front of the abdomen. So laparoscopic is usually done for those patients. So this brings us to the last slide. We've talked about acute cholecystitis, we've talked about biliary pain. As a whole, we've talked about cholelithiasis, which is the formation of gallstones within the gallbladder. We've seen that what are the different types of gallstones, what are the pathophysiology for all those stones, one being the cholesterol and the other being the pigmented stones that are very common. Other than that, we've seen what are the symptoms that usually these patients present with, what are the clinical features, and then we've seen the diagnosis of these cholelithiasis and gallstone disease. Other than that, we've seen the clinical findings and pictures of these gallstones that might mimic, such as the biliary pain if it impacts the bile duct, so it's called as biliary pain, and if there's inflammation of the gallbladder, it's called as acute cholecystitis. So I hope you've enjoyed the lecture today. For more lectures, please log on into sqadia.com. Thank you for watching.